Next slide. Yes, and if you can just look at it, the first image has vertebrae. Vertebrae are like meeting at the joint called facet joint, that is zygophysial joint. And in between the two vertebrae, we have an egg, the white and the yellow in between. And that yellow is a nucleus pulposus and the white is the annulus fibrosus. Again, and if you can just look at the MRI, MRI has got a different sequences, T1 weighted and T2 weighted. The white color, it is loaded with the water. And we have 33 bones from craniovertebral junction to the coccyx, but we have only 23 discs. We have 23 discs. The reason being few bones are like fused. We don't have intervertebral disc interposed in between. And the nucleus pulposus, that is a soft jelly, the material, even like the post-operatively when the surgeon takes this, even if you can just feel it as a jelly substance. And the nucleus pulposus, the white color is totally packed. And we have a disc problems, everybody very familiar with the disc problem. What is disc problem? The nucleus pulposus in the center, it is escaping through the white matter called annulus fibrosus. When there is an annulus fibrosis, it is broken. Again, this disc is avascular. It doesn't have a blood supply. Then how it is surviving? When something doesn't have a blood supply, every tissue in the body needs to survive with only the food. The food carrier is the blood. When the disc doesn't have a blood supply, and how it is taking the food. On either side of the disc, we have a vertebral end plates. It is going to suck the food from the bony ends. That is called imbibition. So when the disc is continuously under the pressure like that, and the next the picture, when the disc is continuously under the pressure, it is not going to suck the fluid. If you want the disc to be healthy and healthiest, you need to provide proper hydration to your disc. And I will show you that I have got one MRI film, how a dehydrated disc and properly hydrated disc, how it looks with the MRI, we can easily differentiate it. So when the disc is completely under pressure, it doesn't take the water from the adjacent the things. When there is no proper the water inflow into the disc is dehydrated. The dehydrated disc always prone to get damaged. Even if your skin is dehydrated, in the winter season, what happens? You see the scales on the skin, we see the cracks and the itching sensation, because dehydration has more effect. We need to put the lotions on the skin. Similarly, when the disc is compressed for the prolonged period of time, there's a reason people people who are chair holding jobs, on the bankers, they sit prolonged period of time, they do complain the back pain. The reason is they put continuous load on the disc. They do not get up with a given intervals. They're in fact dehydrating the disc. And the research guidelines tells that every 40 minutes you need to change the position. If you have to sit for more than 40 minutes, it's better wise to get up in between and take few steps, come back and attend your job. But more than 40 minutes is not advised to sit. Next slide. This slide is basically, till now we were talking about the skeletal aspect of the biomechanics. Now, when you talk of the muscle, in between the muscle there's the blue color one, it's a vein, but I didn't find the image of the red color, the blood vessel. And whenever your muscle is relaxed, the first image, the first picture, when the muscle is relaxed, there is a properly, the lumen maintained, properly dilated the vessel. There is a good circulation. The contracted muscle, here it is compressing your blood vessels. Because whenever there is the contraction, the intramuscular pressure, the pressure within the muscle gets increased. It is going to pack, it is going to compress the blood vessels. Then how long we have to hold the contraction? Imagine you are training somebody, you are giving exercises, either you stretch, you contract it, how long you have to maintain? Because the contraction of the muscle is really hindering the blood supply. But we all need, when you are exercising, the muscle needs good amount of blood, because it always it demand our ATP, adenosine triphosphate, which is a metabolic energy substance. And your muscle has to be replenished with a continuous energy that only happens with the blood supply. When the muscles are under pressure, when the intramuscular pressure increases, it is compressing the veins. How long we have to maintain? Then how, within how much time you can relax us, we'll talk about it. But the picture basically when you contract it, your veins or blood vessels are being compressed. This is enlarged the muscle movement. What's happening, I was talking about when you cut the muscle horizontally, you find the fascicles, Again, you take out the fascicles, you have a muscle fiber. Muscle fiber cannot be seen with the naked eyes. But the imaginary, the picture, the next slide. Next slide, please. Yeah, if you just look at this, is the each muscle fiber. The muscle fiber, again I mentioned, can't be seen with eyes. And the muscle fiber, again, like it has got a blood supply. The muscle fiber, when there is a less blood supply, we all know, like, people we have a metabolism called glycolysis, and we have a Krebs cycle, and we have electron transport. This entire process happens in the muscle metabolism. And if there is no proper blood supply, the aerobic, we have aerobic and anaerobic, there are two techniques in the exercise. When the muscle fiber is not receiving enough the blood from the circulation, the mechanism, the metabolism turns from aerobic to the anaerobic. But we all have to maintain the aerobic mechanism in order to sustain the prolonged period of time. And even there are certain conditions where we train only for the anaerobic. There are two broad categories in the exercise training. One is aerobic training and the anaerobic training. Something called power training. Second one is called the endurance training. For endurance trainers, where they have to sustain the activity from prolonged period of time. So the athletes, they have to walk really so much of time. We have to improve the endurance in the muscle. Imagine the weightlifters and the boxers. We have to improve the power in the muscles. If you want to improve the power in the muscles, if you want to improve the endurance in the muscle, we have a different mechanism to work with them. But we all need, we get up in the morning, we do the household job, we attend the halfways, and we come back, return home. From morning till evening, what we all need? We need power or endurance? We all need endurance because we have to sustain the activity for a prolonged period of time, right? So in order to increase or train the muscles for the endurance, we need to have a good blood supply in the muscle. And if you're not provided, if the muscle is not provided with a good blood, always your exercise turns into anaerobic mechanism. The anaerobic end product is called lactic acid. Lactic acid is the end product of anaerobic metabolism. That gets it is loaded. The muscle is loaded with the lactic acid, right? You have any question now? Okay. So the muscle is loaded with the lactic acid. Lactic acid is really very unfavorable substance in the muscle. But lactic acid is always a reversible cycle. If you can relax, the blood comes, it washes the lactic acid. The lactic acid again enters to the metabolism for the useful purposes. But the lactic acid, imagine today you have given some exercises to some person. After 2 or 3 days, he comes to, I have got a muscle pain. That's called DOMS. We all you would have heard what is DOMS. It's a delayed onset muscle soreness. If you have started your exercise today, after 2 days, you complain with the pain. Why the pain is coming to you? That is an accumulation of your lactic acid. The lactic acid is the metabolic end product. But provided if you are given a proper relaxation, the time, the interval, so between the exercise, lactic acid will never build up in the muscle. It always the reversible, the cycle. Next slide. I don't you are able to appreciate because the image is really dark. And we have, these are the sagittal curves of MRI. And this is again the more focused, the lumbar vertebrae where we're able to see. The yellow color, if I'm talking about this image, the yellow color, it is it is at the L2 level. That is completely a bone. It is a vertebra. It is supposed to be in a square shape, right? The red color one, the disc, just below the yellow color one, there is a disc, again L3, we have a disc, L4, we have a disc. Each and every bone is interposed. And if you can just see that white, the white color where the TT is mentioned, that is a CSF, we call it a cerebrospinal fluid, where disc is supposed to be in its position. If a disc prolapse, what is? From the position, it is migrating into the different direction, where it is not designed to, and it is going to compress the nerves. Right. So always the spinal cord is hanging in the fluid. Even the brain and spinal cord are hanging in the fluid. It is not touching any place. They are in the CSF, cerebrospinal fluid. This image is particularly, we call it the T1 weighted and T2 weighted. We can really appreciate whether the disc is properly hydrated or dehydrated. Can I just get on to the step? If you can just look at this image and this image, the dark color, the circle is annulus fibrosus. The white color in the center is the nucleus. I was talking about the egg, yellow in the center, the nucleus fibrosus. And if you can just look at it, even you all need to have the white color in the center, that is nucleus, and the dark ring. If the disc is not properly hydrated, you're seeing this. Imagine how this disc is looking like. This disc is completely like fragmented. This is called degeneration. What is called degeneration? Your disc is not receiving the proper hydration. It is under the pressure with all your day-to-day activities and the exercises. Like you're putting more the stress on the disc. The next slide. The first image, you can see the discs are at the different stages. Anyone who has the disc it has got many the stages, and we have got a lot of the scientific, the classification, the techniques where with the MRI we classify the disc problems, and with the physical manifestations we can classify it. With X-ray technique we can classify the disc. But MRI is a good choice of investigation to comment the stage of the disc. And universally we have the 4 stages of disc pathology. These are the stages of disc herniation. This is the pathophysiological classification of disc herniation. Disc, it is at the first level where we have the nucleus pulposus. It is started migrating to one end. The annulus fibrosus is broken. Why it is broken? Because it is dehydrated. We are not providing the proper hydration to it because it is a complete under pressure. Then at the next stage, what is happening? The nucleus, the center portion, it is further migrated. And in this image, it's almost the nucleus it has come out. The annulus fibrosus totally it is torn here. And here, the nucleus is dropping. These are called teardrops. This teardrops, the nucleus is falling within the spinal canal, and it is going to, this is again surgical emergency. They have to operate and complete the nucleus pulposus. And people, everybody says I have a disc problem. What stage you are in, right? If you're at the first, second, third, or fourth stage. If you're at the first stage, it is similar like today, I'm 30, after 10 years, after a decade, I become 40, after that 50. I never become 20. Right, my age cannot I can never travel in time back. But here, if you're at the stage 1 disc, you can completely arrest the further deterioration of the problem, but you can never treat. You can't push the disc inside, and you can't suture the annulus fibrosus because it is totally avascular. And if you find a patient at the stage 2 disc, with the help of modern medicine, we can arrest the patient at stage 2. In fact, with the proper treatment and proper assessment and the treatment, we don't allow the patient to go to the 3rd stage. If unguided yoga or improper guidance of medical or anything, the patient easily travels from one stage to the another stage. And this is where from stage 3, this is called extrusion. The disc is extruded. The final stage is called sequestration. The extruded disc and the sequestrated disc, they are surgical emergencies. If again, I am more happy to see patients with the stage 1 and the stage 2, and because where we can satisfy patients easily, and we don't have to struggle too much in order to produce a better or yield a better result in terms of the relieving their manifestations. And the image where the nucleus is migrating in this image, we can better appreciate it. Where the nucleus, the blue color one, is in the center, it is going posteriorly. Because this is anterior, this is towards your abdomen, this is towards your back. Why disc always travels back? Why can't it come to into your abdomen? Because if the disc is coming in this direction, you will never experience pain. When the disc is going back, then only it is going to compress the nerves. You come with the sciatica. We all know what is sciatica. It is an irritation of your large bundle of nerve fibers. This is sciatic nerve. Whenever there is a posterior, the back migration of the disc. But if you take up the 1,000 patients, we all are more prone to even to get the posterior migration of the disc. Why? Because this is anterior part. The posterior part is more weaker. The posterior, the nucleus is more weaker than the anterior. We see even if you can just screen 1 lakh people, only 1 or 2 people you find where the disc is anteriorly migrated. There is forward migration. That is not you never, patient will never come to you with the disc is coming anteriorly. The next slide. Can you just hold on to the same slide? And again, if you can just look this image, the spinal cord, which is coming from the brainstem, which is like going through your vertebral canal, and white color we have like C3, C4, we have a vertebrae, and in between we have a disc. And what's happening whenever the disc is touching your vertebral column, it is highlighted with a red color, and the above and below it's like yellow color. Whenever there is a compression, when the disc is touching your spinal cord, again your entire nervous system cannot survive devoid of blood with a blood supply not more than 3 minutes. There's a reason that all the strokes are medical emergencies. We need to transfer the patients to the casualty immediately, like when you find the signs of stroke. The stroke is, it's like in a layman term you define as a loss of blood supply. Loss of blood supply to the nervous system, we call it as a stroke. And your disc is like going back and touching the spinal cord. The tiny blood vessels supplying the food, the feeding blood vessels are being compromised or being compressed. They can't supply the blood. And slowly the nervous system starts dying. We call it as a myelomalacia. Myelo is nothing but a spine. Malacia is a softening. When there is no blood supply, it becomes softening. Myelomalacia is again not so easily treatable. Okay, next slide. This particular image is the nucleus in the center is migrating. It is in the center. It is posterior. It is lateral. We call, if I see something like this in the transverse curves of MRI, the disc is migrating not only posteriorly, posterior-laterally. The posterior migration of the disc is always friendly, and the posterior-lateral migration of the disc is not so friendly. Because posterior-lateral migration is going to compress the nerve which is exiting from the spinal cord. And today you have given some neck exercises to some patients, and next day, because we do not know what stage of the disc degeneration patient will come to you for the exercises, right? And today you have given some exercises to them. If really the patient is under extruded disc, and with your neck exercises or the neck, some yoga technique, the symptoms started increasing. The pain is always a friend to you. It tells you that something going wrong in your body. And when the nerve is compressed, if somebody comes to you, I have got an excruciating pain which is coming down to my hand and a tingling numbness. If something related to patient presents to you with a tingling and numbness, it alarms something going bad with the nerve. If there is no tingling numbness combined, we call it as a paresthesia. If a patient presents to you with a paresthesia, always you have to stop and screen the patient. If they are not complaining with a paresthesia, tingling, numbness, burning, electric kind of shocking sensations, you can continue with exercises with proper rest of interval. Next slide. There is one more thing. The brain is 1.5 kilo. It's an organ. It weighs 1.5 kg, and it controls completely your body. My senior professor used to always tell brain is like a driver, your body is like a vehicle. If you don't have a proper driver, you never drive your body well. And your driver needs to receive abundant amount of blood supply only from the heart. The tiny blood vessels which are going, there is something called vertebral artery. The vertebral artery, it is going within the bone. That is called transverse foramina of the vertebrae. It is traveling within the bone. Wherever the vessel or the nerve going in a short tunnel, there is a more risk for injury. If something going in a large tunnel, if something is compressing also, it has enough room for the breathing, but it's a very small area tunnel the blood vessel is going, which is carrying loads of blood to the brain against the gravity. If something is towards the gravity, you don't have to worry it. You have a lot of other collateral circulation. If the blood is going against the gravity, brain is sitting in the head and it needs. Again, when you see it from the front portion of your cervical vertebrae, you have two vertebral arteries on either side. The joint within the the calvaria, the brain box, it supplies the blood to the posterior part of the brain, the back portion of your brain. And when you are putting the undue pressure on the blood vessels, and you maintain one particular the side flexion, how long you have to maintain it? Because if you bend it like this, your vertebral artery is getting occluded. So when there is occlusion, blood doesn't go to the brain. But if you have another side of the vertebral artery, that is going to compensate the blood vessel. Imagine if you're bending onto the left, this vessel is occluded, this vessel is supplying the blood, if somebody has a pathology where your vertebral artery is loaded with the fat. The next slide, can I just have it? Yeah, if you can just see this image, within the vessel, there's a fat is sitting. The vessel is like, deposited with the fat. We call it as a atheroma, atherosclerosis. If you're bending neck on one side, this is occluded because of your neck pressure. This side, like, we take it as we taken it for the granted. The another blood vessel is there, is going to take care. But imagine this is being occluded with atherosclerosis. There is less blood supply is going. Patients always complain to us with some amount of giddiness. They tell you like, I'm getting giddiness, like if you maintain this posture, immediately there's a warning sign again. You have to quickly reposition the patient to the normal. If you really closely observe it, there is something called nystagmus. Nystagmus is a horizontal rotation of your eyeballs. If you kept the patient in this position, your brain is receiving the less blood supply. If you just open the eyes and see, like, you see the nystagmus. Nystagmus is again a negative indicator. And the patient, like, verbally, not all the patients I'm getting giddiness, like, they will never complain. Whether in order to, they wanted to do some exercises, so the minor complaints, they always, like, tend to take it lighter, but always you need to educate your clients or the subjects or the patients. You have to give them the checklist for the warning signs. If you are finding these things, you please immediately, like, alarm us. We will be able to provide you the alternative technique. But these vessels, they're supplying the blood. If there is atherosclerosis, it's really, we have to be very, very careful. Nowadays, because of our lifestyle, we are, like, not carrying a good dietary the plants. There is more risk for the hyperlipidemia. There is, like, more the lipid deposition in the body. That is, like, sitting in the major vessels. Because something bad to the body happens only, like, in the vital organs, like, heart and the brain. The more fat sitting, there is a reason more the people are more coming with the strokes. Because of the fatty deposit anywhere in the hands and the legs, like, people will, it will be, we never call it as an emergency. And the fat is going to, that is a favorable environment. Let me target this guy because I want to just kill him. Because the fat knows very well, the heart is very vital and the brain is very vital, because it is going to, like, sit in the blood supplying areas. So we all have to be very careful. And the carotid, this is in vertebral arteries, like, there is something called the large vessel in the front portion of your neck. We call it as the carotids. We have a carotids on either side of the midline. You can always feel the carotid, the pulsations. With that also, like, the ancient medicine, they used to tell the patients, like, if they come to the stroke, whether it's an ischemic stroke or hemorrhagic stroke, whether the patient has stroke with the clot or the bleed, they used to tell with the help of, like, the pulses. I really wonder how they used to manage when all these investigations were not available to us. The next slide. And this is again very important, the point which I would like to put in this discussion. There is something called osteoporosis. Everyone knows this. What is osteoporosis? The density, the strength of the bone is becoming less. When the strength becomes less, we call it as a weaker bone. In the medical terms, we call it as this is a normal bone. This is the osteopenia, that is osteoporosis, the severe osteoarthritis. That is not the right image. Like, you just so look at these the circles. The osteoporosis is not so friendly condition. And really in the hospital, the doctors are really struggling to treat this problem. More often, the women are more prone to get osteoporosis because they have the cycle, the menopausal issues. The hormones are really, they are like an amrutam for us, because hormones are completely like, chemical messages are managing the body. The hormones are going to maintain complete homeostasis of the body. If people who do not have a proper estrogen and the testosterone in the males, and it is going to affect your first bone density. Why it is affecting bone density? It is a large tissue. From top, the skull to the bone is completely a skeleton. Where here in this image, your bone is properly like cannulated. Yet there is like all your the canals are like widened, and you can see like more air fills the gaps here. Because the calcium, which is a deposit, the calcium is like a cement in the bone, and you need to have a vitamin D to transport the calcium to the bone from the intestines. And here what's happening, and the people with the normal bone and the osteopenic, you can give whatever we want. We can handle them without any proper care. And the people at the osteoporosis, it's really sad. Recently I have seen one 75-year-old lady. She has been taking yoga lesson instructor. She landed with the L1 wedge fracture. Remove the bone, we have to put the screws and bones. Luckily, the nervous system is not been compromised. Imagine if this is a treatable cause, we remove the bone, that is called carpectomy. They are going to decompress the spine and put the screws on the steffi rods. If that is really compressing the nervous system, she is going to lose her legs. Losing the legs is almost okay. Then losing the urine control and motion control is again pathetic. Imagine 75-year-old lady at home who is there to serve her. Psychologically, it's a burden, and it's a big burden to the family, and there should be somebody to take care of it. And 75 years, losing urine control and motion control. Imagine if we are at here, it's completely embarrassing situation. So kindly take this message. Yeah. Because she was telling me with the poses, because she was my old patient. She has got a rheumatoid arthritis from past 15 years. Again, note this point, 15 years she is under corticosteroids. Corticosteroids are really it ruins your bone density. From past 15 years she is under corticosteroids, the bones are becoming weaker, and we do not only sit-ups. When she is doing the sit-ups on the bed, she suddenly fell. That moment, she started experiencing the pain. From next day, every day the pain started getting excruciating. At some point, she was brought to the hospital. That was the incident. That was more. From that day, the pain started again. Yes. She fell, but she has a comorbidities. She fell on the bed while she was exercising, and she fell on the bed. She started the pain journey started. Not everybody with that small amplitude of pressure that is not going to break the bone. She is at the vulnerable risk because she has been taking corticosteroids from past 15 years of duration. But we are the treating people, we need to consider complete this history when we are, because we need to customize it. Not every patient we can't give the routine therapy for everyone. That poor lady now 3 days ago we have discharged her from the hospital. So osteoporosis, because osteoporosis doesn't leave any bone in the body, it is every bone is favorite. So it is going to affect every single bone in the body. You all have to be very careful when the patients with osteoporosis. We have a very simple and cost-effective investigation called bone density measure. That tells you whether your client is at normal bone density or the osteoporotic. But taking it for the granted, even the women after 40 years, the men after 50 years, we have a 10 years average, the gap, the difference between men and women health. After 40 women, after 50 the men, we all have to screen for the bone density, because osteopenia, there's the journey of the body physiology. Somebody is at the penia, we can always maintain it. The osteoporosis, we have to be really careful. Osteopenia and osteoporosis, it can be really controlled with the naturopathy techniques and the physical, the lifestyle, diet plus exercise equal to lifestyle, we all call it as. We have, when I was doing my post-graduation at Nizam's Institute of Medical Sciences, we have done a small survey. We have taken 100 post-menopausal women, and they were given with the calcium and the exercises. We call it the weight bearing. The weight bearing onto the bone is a tremendous technique in order to strengthen your bone. Imagine somebody has moved to the moon space. Once they come back, if you check the bone density, the people traveling from the space, the bones are so brittle, even if you can twist them to break. People coming from the space, because there is no weight bearing on the bones, right? That's the reason we train them. Even once they come back, this is called astronaut rehabilitation. We treat them to, we have certain time frame. We can't expose them directly to the outside environment. We train them because bones become so brittle. We have 100 women we have taken above 50 years where they were supplemented with the calcium and weight bearing exercises, one group. Another group with only calcium supplementation, another group with only weight bearing exercises. We have 3 groups. And we have taken bone mineral density test, and after 8 weeks of the therapy, we have done the bone mineral density. People who are on calcium with the weight bearing, there is a tremendous improvement of the bone density than people only taking the calcium, than people only exercising. We all have the tons and tons of calcium we drop in the GIT. Are we really feeding the bones or feeding our tummy? Because ultimately the calcium has to reach the bone, the transporter via called vitamin D. And if you're just simply infusing the calcium into the body without proper lifestyle with exercises, bone doesn't take it. Bone is not like us. Bone is not just like us. Even we work today, we don't work today, we eat. But bone is not like that. If you work with the bone eats. If you do not work with the bone doesn't eat it. I say I have not worked today, I don't need calcium enough. Because if you allow me to work, then I eat it. So the reason that talk about all this in extensive way, the osteoporosis is a serious complication. We all need to address it and check with a simple test called bone mineral density. In all the laboratories it is available. It's a simple, non-invasive and cost-effective investigation in order to check the bone density. Next slide. Yeah, madam, you were asking this question to me, somebody. Madam, the ligament injuries, right? Now, how long you take to treat your ligament injuries? Sorry, tendon injuries, or it is both the structurally they are same. And there is a tendon, this is called a TA tendon, tendo-Achilles. Your calf muscle are finally becoming your tendo-Achilles, the tendon, and they are taking insertion at the calcaneum. There's a heel bone. And people with the wrong technique, without proper guidance, say unguided things, and they can land into grade 1, grade 2, grade 3, the tears of injury. When there is a grade 1, there is a minor stretch of the tendon. Grade 2 is 50% damage to the tendon. Grade 3 is complete 100% cut of the tendon. But with all our improper techniques, we never push the patient into grade 3 because grade 3 injuries will only happen with the trauma. With a high force, it is going to break the tendon. Tendon is a very strong structure. But if there is an age-related, if there is a degeneration, tendon also becomes weakened like a bone. And we all see with proper improper exercises, we can see the grade 1 tendinitis or tendinopathy, or this is very common. But all these tendon injuries, with lower extremity tendon injuries can be treated differently. In the upper extremity, the tendon injuries are treated differently because lower extremities, the tendon injuries are the weight-bearing areas where we have to be more careful. Right? There is something called RICE. Anybody heard of RICE? What is RICE, RICE? With any grade 1 injury, you heard it, sir? Yeah. See, RICE grade 1 injury, if any of our patients are they're complaining the tendon injuries, we assume it is tendinopathy, and simple physical examination we can say the tendon is injured or the bone is injured. Without they seek the advice from the physician, we can always advise them. We can take this as for the granted, RICE. R stands for rest, this is most important. I stands for icing. C stands for compression. We need to give some compression stockings. We don't allow there is too much amount of pooling of the blood. The pooling of the blood too much, without blood, with excessive blood, both our extremities are dangerous. We need to get an optimal amount of blood. This R stands for rest, and I stands for icing, C stands for compression, E stands for elevation. So we need to immediately put the patient under this before they meet any specialist. Next slide. And this is very important. The reason being put this slide is anybody can interpret the X-ray very easily because we all are trained medically. And if you can just see this red line, which is running the front of the vertebrae, this is called anterior vertebral line. It has to be straight and smooth. There's a posterior vertebral line, there's a posterior spinous line and laminar line. These four lines are in continuation because this red line there is no irregularity in the line. The line running from the craniovertebral junction, the entire cervical spine, this doesn't have any notches. It doesn't have any irregularities. This is smooth line. This is again the smooth line. These are all the smooth lines. If there is an instability, if there is one bone is moving on one another, you can see there is a notch. If there is a notch, if there is a kink in this vertebral lines, we say the particular area of the bone, the vertebral column is not stable. So that needs attention again. The next slide. Yeah, there is, imagine, if you can just look at this image or the first one, the line is not running smooth, right? If you draw the line, the front of the vertebrae, the line is like no kink there. The line is not smooth. The line is kinking. It means there is one vertebra is not in its position. It is migrated or moved backwards. There is something called spondylolisthesis. Spondylolisthesis is a displacement of one vertebra over another. And majority of the time, again, like women are more prone to get this problem because of the repeated, carryings, deliveries in the postpartum. Because the tendons becomes weaker, the bone can escape from its position. That is called spondylolisthesis. Even spondylolisthesis, we have different grades: grade 1, grade 2, 3, 4. And grade 1 is there is a 25% of the slippage. Grade 2 is less than 50%. Grade 3 is 55 to 75% of displacement. Grade 4 is complete 100% displacement of vertebra over another. Because why I'm talking about this, sometimes we give them exercises like, these are flexion exercises. These are extension exercises. You say there are thousands of exercises like bending the trunk in front. There are thousands of exercises going your trunk back. But in case of spondylolisthesis, complete extension exercises are purely contraindicated. If somebody with a back pain, but we always whatever we have exercise, the methods and the mechanism, we take the patient the flexion strengthening and the extension strengthening. If people with spondylolisthesis, irrespective of the stage, whether it's a stage 1, 2, 3, 4, if it's a stage 1, if you train them with extension exercises, you're forcefully pushing the patient to get into the stage 2. And if you're further putting the extension exercises, you're pushing the patient to go for the surgery in order to you're facilitating the deterioration. So if the patient has a simple X-ray technique, we can say that the vertebral bodies are aligned properly or not. So we'll be able to know with the help of those 4 lines. Those are called vertebral imaginary lines. If the line is proper, yes, it is fine. If the line is improper, yes, we need to look at it. Next slide.
I have a doubt.
No, the back pain, again, we have the back pain. Why there is a back pain? The pain comes from the muscle. The pain can come from the back tendons. The pain can come from the back bones. The pain can come from the intervertebral disc. The pain can come from the nervous system. And people who have the tumors, we call it the lesions in the vertebral column. For every single problem, pain is an indication. And pain is not an indication for the exercises. Pain is an indication for the investigations. Pain is an indication for the screening. Pain is an indication for the examination. We have to examine the patient properly with what cause the pain is occurring. We need to first address it. Pain is not an indication for the exercise, right? With what cause the pain is coming, we need to understand it. You understand my explanation? Yes, because examination is very point. I think this is this particular class is really beyond the scope of your question. We have something called complete neurological examination. Neurological examination doesn't require any kind of tools or the machines to tell this particular patient should go for this exercise. We have 2 page, the assessment sheet will tell you what exercise you can indicate. We can really exclude all the checklist points. Yes, patient doesn't have this problem. With physical palpation, we need to train our hands and eyes to look at the patient to tell, yes, this is indicated, this is not indicated, this regard. Just your yes.
As a yoga instructor, you should ask
not everybody come to you with without any physical problems. Nowadays it has become more common. Unless until we have a pain, we are not coming to yoga. This is it. I have a pain, I am going to yoga. For what it is, if people come to you without any pain, without any manifestations, then you can go for it.
So lower back pain is very common.
Very common.
So how we will come to know the exact reason of that?
Yeah, that's what there's the answer. Again, I repeat, you have it. Yes, the physical examination you can easily so hands-on. You can just train. You have your patient in front. You have we have a checklist. Yes, patient has this, exclude this. Patient doesn't have this, include this. We have a checklist, and simple assessment findings. On one or two assessment findings, you may not train yourself. Do the same assessment on hundreds of patients at end point. You'll be able to really train yourself how to exclude all these kind of vulnerable issues. And simply, the summary is, if somebody has come to you with a back pain, we have to first examine them for what reason they are getting it. And if somebody comes to us without back pain, you take them for granted, whatever exercises you do it. But after exercises, if again they are complaining the back pain, you again evaluate them for the reason and come to your conclusion.
Because every yoga instructor is not a doctor.
That's nice.
And yeah, we are not highly qualified.
I agree with you. Yeah. This is yoga instructors, if we can just have a practice of patient examination, there is something called history taking. And how many of us we really spend time for the history taking? How many of us really spend time for the examination? If the client comes, we start with the exercises. If you find with an history, if they have a past medical history, you tell them to give us your past medical history report, you go through it. If you don't understand, start reading those points. And this sort of personalized training will help you to serve in the future patients very well. Okay, so you always need the history taking. Second thing is examination. These are the two weapons, I can say, to facilitate the good care to your patients.
History taking is important.
Yeah, very important. History taking, very important.
Nowadays, nobody is taking it.
Yes, sir. And history taking, we have to really give that. Imagine you are a patient, you are going to meet a doctor. If they are not paying attention to listen, you are bothering. Do you feel he's a good doctor? Whether he is doing the good medicine or not, you don't mind about it because you do not know anything. But the doctor or any yoga instructor should listen to you first, what you are saying. The listening capacity always heals always 50% of the case. But it is in vague terms, but always listen to them with the proper history, examine the patient, then after that only the treatment. Don't enroll your patients directly into the therapy. That will sometimes not every patient it will push them into the problems treating 99 clients and spoiling one patient is again not good. Right? You really have to feel guilt about it. See, this X-ray is really, ma'am.
Question
Please,
regarding
please.
the previous slide. Spondylitis and the previous slide.
Spondylolisthesis.
Is it different or
Different, completely different.
Can you explain?
Yes, spondylosis. You want what? See, spondylitis is different. Spondylosis is different. Spondylitis, spondylosis. There are different conditions, but there is something called degeneration. I told you, degeneration is a term. It means age-related process. Today we have a black hair. After a few years, it becomes a white. This is called degeneration of the hair. We are able to see better. We develop a cataract. There's a degeneration of the visual acuity. We have normal bones now. We the knee started hurting. There's a degeneration of the knee. We all need to understand something called degeneration. It's the age-related process. Spondylosis is the age-related process of your spinal cord, vertebral body. Either it can be a cervical spine or the lumbar spine. What happens? It's only degeneration. It means, because I don't have an X-ray now, we can really see a normal X-ray. We can see whether the spine is degenerated, even it has got certain stages, degeneration or not. But can we just have a previous slide, please? Yeah. So this first I'll talk about spondylolisthesis. This is an upper vertebrae. This is a lower vertebrae. The upper vertebrae is moving on lower vertebrae. This is complete 100% displacement. This is something about 50. This is 25%. The displacement, movement of one vertebrae over another, we call it as a spondylolisthesis. Spondylolisthesis is the displacement of one vertebrae over another. It doesn't need a trauma to cause. Sometimes the deliveries can cause this problem, right? Grade 1 listhesis, right? And spondylosis, if you can just appreciate this, the disc height. If you can just see this is a vertebrae, this is another vertebrae, we have a disc here. Imagine this is called a disc height. disc height here is different, disc height here is different. There is a reduced disc height. This is spondylosis. If you just look at the X-ray, the gap between this here and this is like reduced. It is like one indicator, the reduction of disc space between the vertebral bodies. It is spondylosis. Listhesis is completely a displacement. It is like moving from its one position. And if you can take the X-ray, you just draw the lines. You'll be able to see it whether locis or lysis. Next slide. And I want really every single person here to pay attention for this X-ray, because the exercises what we give to the clients, it really matters. We cannot take exercises lighter. Exercises acts like a medicine on the human body. The simple X-ray, the patients who have a spondylolisthesis, the previous image like the displacement of one vertebrae over another, it has different percentages. The flexion, we have taken this X-ray on the same day. You see like here, this X-ray is taken with extension. This X-ray we have taken with extension of the spine. You see the displacement of the vertebrae. And this X-ray we have taken with the flexion of the spine. You see the gap is reduced. The disc is already, the vertebral body is displaced, but this is called dynamic X-ray, just to rule out, to check the instability. If you check the flexion, we usually bend the patient like this, we focus for the X-ray. We completely extend the spine and take the X-ray like this. And extension X-ray, there is a large difference between the two lines. The gap is increased, okay? Sorry? Yeah, this is extension, this, no. Yeah, this is extension has reduced it, and flexion. Again, this patient is also like traumatic indication. The reason to get it is, usually the extension always increases, the flexion always reduces. The patient has associated bony fractures also. And you remember only one thing, the flexion is encouraged with the listhesis, the extension is not encouraged. Extension usually going to displace the bones dramatically on the single movement. So you appreciate the differences between the two lines, how they are moving in each position.
Does it apply to spondylitis also?
No, it doesn't apply. It doesn't apply. You need to strengthen, that is called global strengthening. You need to strengthen the flexors, extensors, and the side flexors also. That's called global strengthening. We need to do in case of spondylitis. But spondylolisthesis, we need to do injustice. We are going to strengthen only one group. We are not going to touch the other group, because we need to have a more strength in one group of muscles in order to hold the bone on another bone below. The next slide. Again, the reason to talk about it, the X-ray, the patient, he's father of one of my junior, he's working in my team now, and he recently underwent the surgery. They live in somewhere other the district. And you see, this is something called artificial disc, the cage. The intervertebral disc is completely removed and placed in artificial disc, and the bone is stabilized with the screws and the rod. And you see the another image, the intervertebral, the bony cage is completely displaced to the another end, because he was doing exercises without supervision, without proper guidance. Again, they have come to us. He underwent the second surgery. He's a father of one of my colleagues. Recently it has happened without proper exercises, without proper guidance, how it is going to affect. Because the entire surgery is costing around 3 lakh rupee. It's a financial burden again for the second surgery. Again, the amount of pain the person undergoes is really cannot measure it. And second surgery always will try to weaken the muscles. And for the rehabilitation, for the next level of the recovery, it takes a really prolonged period of time. The next slide. Yeah, there is something called, am I overloading? Is it okay if I can continue? There is something called microfractures. Microfractures are something cannot be identified with X-ray. Microfractures can only be appreciated with a 2-dimensional or 3-dimensional CT scan. And this is the image where you see we were talking about the normal bone, osteopenic and osteoporosis. Porotic bones, if we are exercising them without proper history taking and the screening and proper guidance, you're going to impact microfracture the bones. Today, microfractures cannot be identified with X-ray, and with X-ray evidence, yes, your X-ray seems to be all right. You do not have something wrong with the pain, because X-ray is a 200 rupees investigation. 3-dimensional CT, 2-dimensional is almost we need to pay 4,000 or 5,000 rupees. Everybody is not, they can't afford it. So not for every patient we don't tell them to do this investigation. But micro tears are something where if there is a tear, what happens? There is a swelling. We know what is something called inflammation. Inflammation has certain signs. When there is an injury, there is a redness, there is a swelling, there is a warmth, the temperature increases. These are called signs of inflammation. When there is a micro tear here, micro tear is some sort of injury to the bone, it increases the inflammation. The inflammation, one of the signs of inflammation is also the swelling. The swelling under the skin is different. The swelling in the vertebral body is different. The swelling is going to again compress your spinal cord. The spinal cord is very sensitive. It doesn't bear any sort of insult. If somebody insults me, okay, I'm fine. I take it light. If we all come across a lot of insult, the nervous system is not like that. If something insults to its routine function, it compromises. I am not going to do this damn thing because you have insulted me. First remove this insult, then I'm going to function. First remove this compression upon me, then I'm going to function. So this micro fractures of the bone is going to cause increased swelling and the compression, where it's again not nice to function. Next slide. Next slide, please. So how are we going to prevent? What is the key for the prevention? So what is the key for the prevention? We will talk about it. And this is basically to highlight my experience here. And this is not thing to extensively talk about how we're going to prevent it. But few points, the bulletins I'm going to leave here. How are we going to prevent all these kinds of massive destruction? The next slide. So prevention is always better than the cure, and we all need to have a proper guru and a proper guide to train the people. Without proper guidance, and nowadays whether the guru is properly qualified or not, we need to always check. That is most important, right? And prevention always carries more weightage. And is my time up? This slide. No problem. Next slide. Next slide, please. She's going to change. Prevention is again a proper evaluation of the subject, and always your examination is broadly categorized into two: subjective and objective. Subjective is what patient tells you, you have to listen. That is subjective. Objective is what you're going to find on the patient. Okay, when patient tells us, we never discompromise them I have a pain. We tell them no, you don't have a pain. You can tell that because it is their experience, pain, right? There is subject to what they tell you. We have to listen. What we examine, because there is something called hysteria. Patients do come to us with n number of times without any complaints also. That category is entirely different. That is called pretending. They always feel I have something. That pretending, that hysteria, those conditions are different. But usually patients, history, and your observations always we need to collaborate these two branches. Next, customization. We get all the patients. We should never include them in the group start exercising. That is a completely not good way of practice. You give them the time, examination. You give them even the exercise part also. You train them for a few days. If they're okay, if they're tolerating your exercise schedule or your regime, then you mix them into the group. That always gives you the good result. Next slide. There is something called Valsalva. I quickly take 1 minute of time to explain it because this itself it is going to take more time to talk. There is something called Valsalva. What is Valsalva? It's a forced breathing and closing the glottis. Glotting is there. The glottis is something is a trachea. You completely fill your lungs. Take it complete, each inhalation you are taking 5 liters of oxygen. You take extra 1 more liter, 6 liters, and close the glottis for little more time. So what is happening? There is a sequelae of incidents happening because the deep inspiration and closure of glottis, we call it as Valsalva maneuver. always discourage your clients to not to practice this, because deep breath and holding while you're doing breathing exercises, deep breath and holding, that is not the thing. When you're exercising, you should not hold the breath. Exercise, don't hold the breath, because that is going to increase your intrathoracic, the chest pressure, intra-abdominal pressure. That is not going to send the proper blood supply. The tiny blood vessels, according to the age, even blood vessels gets degenerated, there's a chances for the burst. Majority of the time, we get the patients to the casualty, the emergency department, the morning falls. They go to the bathroom. Majority of the people, they have a constipation. They do the Valsalva while defecating, because when they're passing the stool, they force the stool out with forceful inhalation, they close the glottis. There, majority of the patients we get, there is something called intracranial bleed. They have to break the door, bathroom door, they have to pull them out. And morning strokes are always reason, this is the reason, because they do the Valsalva and they land up in a stroke. So never encourage our patients the Valsalva manual. This is really very important information. Next slide. I really thank everyone. Anybody has any questions?
The same that
Yes, ma'am.
like how much time to hold the contraction?